Welcome back to yet another episode of the Pathway Podcast. I'm your host, Nino, and I'm back in the studio with Dr. Sebastian Rodriguez Elizalde, this time with meta glasses on. How's it going, doctor?
Great to see you, Nino. Great to see you. Yeah. I use these a lot for work, actually, sometimes.
What's your favorite feature on those?
To be honest, recording video intraoperatively, we do a lot of teaching and have to create a lot of video content for educational purposes. And we've played around with cameras and lighted mounted cameras and professional companies and iPhones. And I found actually the meta glasses have been the most reproducible from like a POV of the surgeon, right? When you're doing stuff, and pretty seamless recording. There's no glare, nothing gets in the way. So they're very helpful for that.
Interesting. We might get a POV of podcast with pathway surgery, but we'll see.
Maybe I'll get Meta to record one of those in a bit.
You'll see. So today we're talking all about robotically assisted total hip replacements. So just to contextualize the conversation, as we always do, describe to me a little bit about the hip. What's the articulation? What are some of the supporting structures involved here?
So the hip joint is made up of really two major bones, right? Your pelvis. Inside the pelvis is sort of a cup, which is called the acetabulum. And that's sort of the socket, if you will. And then you have the ball of that socket, which is attached to the femur. That's the head of the femur. That's your thigh bone. So people often get confused, when they say I have a hip fracture or a thigh or a femur bone fracture. It's really all the same. It's your hip joint is comprised of those two major bones. Now, around those bones, as you can imagine, there's a lot of ligaments and capsular attachments, sort of that bag of connective tissue which attaches the acetabulum to the femur, and multiple muscles. So a lot of muscles cross both joints, which give sort of power and motion to the hip joint and allow it to move. As a ball and socket joint, as you can imagine, it can rotate, flex, and extend, giving it sort of not 360 degrees range of motion, but pretty close to in terms of its possibilities.
Right. And today's conversation is obviously total hip replacements. So I think a lot of it is going to be centered around osteoarthritis of the hip.
Yes.
And that's a word that is thrown around a lot to varying degrees of understanding. So if you can break osteoarthritis down simply, how would you describe it?
So I think that's key to understand. A lot of people, and we sometimes even shorten that to just arthritis. And for a while, a lot of people got confused because there's a lot of inflammatory arthritises that are out there. So you can have something like rheumatoid arthritis or psoriatic arthritis, and those are all sort of inflammatory processes. They can all eventually lead to something called osteoarthritis, which is really that degradation of the cartilage. So like the knee joint, the hip joint is, surrounded with cartilage on the articular surfaces. So your acetabulum, that cup is lined inside with a nice smooth synovium is hyaline cartilage, which is that smooth lining inside the acetabulum, and on top of the femoral head as well. Hyaline cartilage encompasses that. And around those two cartilage sort of articulations, you have something called the labrum, which sort of acts like a meniscus in the hip. It's like a little bumper of cartilage, which is movable and can flex and extend and be shifted around. But really, it helps to give a better suction fit of the femoral head and neck and disperse the contact pressures between the two bones.
Right. So
Osteoarthritis is then the degradation of that cartilage. So that cartilage can be either traumatically, affected or over time. So like the Teflon on your pan or the tires on your car, with time it can get wear and tear.
but not the lenses in your meta glasses.
Not the lens of my Meta glasses,
right.
though. Those are indestructible, I think. I should ask, the guys at Meta. But yeah, and so that cartilage can degrade over time, traumatically or even just, if it's had repeated injections or repeated trauma of any form, even infection. So any insult repetitively to that joint can lead to degradation of cartilage. And when you get that, you get sort of these pits and crevices where the fluid in the joint can get pushed into the bone. That can lead to cracks or insufficiency fractures slowly. And what happens to the hip joint is it starts to flatten out. So it's a very symmetrical ball and socket. As you start to lose that sphericity or that perfect symmetry of the femoral head, those irregularities cause increased contact pressures, and that leads to more degradation and more wear to the point where it's very painful to move because the hip is now not a congruent joint anymore.
Right. So I think that sums up obviously osteoarthritis perfectly. And we were speaking previously about the knee joint and some of the mechanisms involved in the development of this arthritis. And we talked a lot about there's genetic maybe predispositions, valgus varus misalignments, maybe an acute trauma to that knee joint. What's kind of going on in the hip, and are the mechanisms of the development of this arthritis similar?
So any arthritic processes, when you have sort of these joints that are designed to deal with pressure and motion. So anything that increases pressure or decreases motion can lead to, predispose you to degenerative changes. So in the hip, you could be born with a hip that's not perfectly formed. And at that time, it may not bother you, but then the hip could be either dislocating or subluxing, which means to sort of pop in and out. When you do that, you put a lot of pressure at the points of where it's popping out. And that could lead to earlier osteoarthritis, something in your 20s or 30s or 40s, which we normally don't expect to see until you're 60, 70, or 80.
Right.
So the anatomy of which you're born with can certainly influence that, in terms of be it either micro instability, so something that causes the hip to move. So we know someone who's had repetitive labral tears that aren't
Right.
addressed, maybe, or have had dislocations of the hip. They can have micro instability, which leads to wear and tear of the hip a bit earlier on. People who've had infections as a child in their hip can be predisposed to this. And then people that have just slightly misshaped hips. And what that means is sort of people use the word dysplasia a lot, which means sort of like not normal sort of anatomy. And it can be even very, very subtle in people that's just a few degrees off or a few millimeters off. But that can increase the contact pressures in the hip quite a bit. And when you have uncoverage or a lack of coverage on the femoral head, you get more contact pressure. And when you have more contact pressure, that cartilage takes more load and over the years can get eroded much quicker and hence could lead you to osteoarthritis. All
So
of that being said,
right.
there's still a genetic predisposition. So if
Right.
you look at females, especially if you look at, did your mom have hip arthritis? Did your sister have hip arthritis? Like, oh yeah, they all had hip replacement surgery. Like that's not uncommon to hear in some females that also have a genetic predisposition.
So with that, are females more genetically predisposed than males to the
Not
development of
necessarily,
arthritis?
but they can be like later on, like, like later on our patient demographic and the elderly females are more predisposed to hip arthritis. For males, it's often associated up until recently with a lot of sporting. So high vigorous squash players at a competitive level, competitive hockey players, anything that involves a lot of deep hip flexion repetitively, or explosive power and jumping like basketball players, all those people at a really high professional level, and if they train for so long in decades, definitely predisposed to hip osteoarthritis.
So it's kind of analogous to the knee and I guess the arthritic process in general, that it can either be chronic overuse injuries where you're not maybe you're participating too much in sport and you're not giving the hip enough time to recover, or you might have an acute injury damaging that labrum, and that could potentially lead to OA down the line.
Absolutely. So it's generally seen as all our joints and our body in general wears over time, and cartilage in the hip and in the knee or anywhere else in the body is no different. Over time, all our soft tissues don't become quite as robust as they used to, even our bones, and certainly the cartilage lining our joints. We can speed up that process, unfortunately, by repetitive trauma or isolated trauma in terms of sporting accidents or a car accident or a slip and fall. All of that can sort of, be a kickstart to sort of speed up that process in many instances.
Right. So that's kind of the you can call it the anatomy and the mechanisms of developing OA in the hip. Now, in terms of actually now treating this and getting to the root cause, who's a good candidate for a total hip replacement? And we'll definitely get into all the robotics involved in that as well. And what are the considerations that you take in your practice when looking at a patient to decide if they're a surgical candidate?
So I think like, any major surgery requires to see if like that patient is ready for surgery. So if they've come in complaining of pain at that affected joint for a number of years that is not easily modifiable with oral medications, as we talked about, or physiotherapy, or even trial and injection without much success, I think, and then radiographically, you take that clinical picture and you match it to the radiographs, be it typically x-rays or sometimes an MRI or a CT scan. And if you can say like that person has degenerative changes consistent with arthritis in the hip, um, those two things together, and if that patient is now affected by that, so their activities of daily living, like, I can get by, but I just can't go for long walks anymore, enjoy time with my family, or get back to sporting types things, or even go to the gym. Once it's, you have the symptoms, you have the radiographic findings, and it's affecting their life to a point, I think they're ready for hip replacement surgery. And I say that because hip replacement surgery, we used to think was something that was only a one-time thing. And I think we talked about this before. It wouldn't last very long and you have to really wait till you're crippled. But we're realizing more and more it's going to be very good at restoring people's quality of life and getting them back in the game, be it that game of life, that game with grandkids, that game, whatever it is, like you can get people back to high level functioning with a hip replacement.
Right. And I think the goal of these podcasts is to inform everybody at home listening about these procedures so
Yeah.
they can be informed and make decisions for themselves. And I think you alluded there to a potential myth in this, which is I should wait as long as possible to undergo hip replacement surgery. So you would say you disagree with this?
I do disagree strongly with that. And I think that was the teaching to us. And part of the blame is that we taught family doctors that don't send in referrals unless they're really crippled or severely affected to come for surgery, because these are seen as sort of surgeries that we don't know how long they'll last and one-off things. And now we've come to realize over decades of research and decades of operating that, these surgeries last much longer. So 20 plus years for hip and knee replacement surgery. And the possibility of redoing that surgery is actually much easier than what we initially anticipated. And so people can even have a second, even potentially a third operation and still get good quality of life and function. So the threshold to have surgery shouldn't be that you're in a wheelchair and excruciating pain. It should be once it's affecting your activities of daily living or impacting your life to the point where you're changing the way you live because of that pain and nothing else is helping, you should seek advice from a surgeon.
Right. And I know in the knee, you mentioned this previously, that there's some things you can do during the clinical exam that help you determine that this patient is a candidate for maybe a knee replacement. What's going on in the case of a clinical examination in the hip? Are there additional exams or assessments that you're looking for tests that might be positive that make you decide that this person's a candidate for this?
So I think in either case, that physical exam starts by just watching how that person walks into the exam room. So coming down the hall, are they using a cane? Are they using a walker? Are they limping? Are they favoring one side? Are their gaits, are their strides shortened on any one side? These are all things that you sort of intuitively start to pick up on people.
Right.
How do they transfer from their seat to the exam table? How do they even lie down? Do they have to use their hands? Can they lay down? All of that sort of the more subtle part of the physical exam, you sort of make notes or mental notes on in your head. When you take the hip, the big thing you do is take it through a range of motion. So classically, hip pain is really presented as in the groin. That being said, people can present with isolated buttock pain, thigh pain or muscle pain, or even just knee pain, and their hip isn't that affected. So you have to examine all those joints and all those areas, take it through a range of motion, specifically hip flexion and internal rotation causing an exacerbation of their symptoms is sort of the classic way to determine if people have hip osteoarthritis. But if we're ever worried or we're not sure, we can use things like injections, especially in the hip, because the back can cause problems or the knee can cause problems, or we're not sure. Therapeutic or diagnostic injections into the hip joint are not uncommon to help get an idea. And what I mean by that is we put some freezing actually into the joint under ultrasounded guidance, and that can be done by your surgeon or by a radiologist. And if the patient gets relief from that, then okay, the problem is in the hip. It's not in the back or it's not in the knee. And that gives you a lot of clarity and answers when you're not sure what's going on.
Right. And would the labrum be considered as within the hip if you're giving this nerve injection and they feel better?
Yes, absolutely. So a lot of my sports colleagues will also use diagnostic and therapeutic injections into the hip to help delineate sort of, labral pathology, which can be seen on MRI. But if you want to make sure that's what the pain generator is, a lot of people do those injections.
Right. I think we've contextualized this conversation nicely in the anatomy and the pathology of this development. Now, I think for the meat and potatoes of the podcast, looking at the robotics involved in this. So you're an orthopedic surgeon that specializes in total hip replacements. How do you use robotics, and how does it help you in your day to day?
So I think you have to remember, like all these surgeries are sort of very mechanically oriented surgeries. They're sort of like engineering for the body, be it you're replacing parts of the body, hip or knee. And that involves, understanding that you have different pieces and sizes that go into different bodies that are different shapes and sizes, and reproducibly being able to reconstruct the body or putting those pieces of metal and plastic into the body exactly where you want to put them. So being able to understand the surgery, that's the sort of the artist craft of this. Is that's why years of experience with a surgeon, you know, even until now, is always helpful, because the more you've seen, the more you've done, the more you have understanding of the feel of the anatomy, the better you as a surgeon will be. But on top of that, now we have additive technologies like navigation and computers and computer navigation and robotics. And all these things help us understand better what we're doing at the time of surgery. Because a big patient and a small patient can have very differing anatomies and can have technically different, challenges. You can have bone that's particularly soft, or bone that has a different anatomy or shape or size. You can have soft tissue that's, in a bigger patient is hard to get to because the patient might be overweight. You can have someone that's exceedingly muscular and it's very difficult to dislocate the hip or difficult to do the operation. So any technology that gives you reassurance as a surgeon to better position the metal or the components where you want to put them, I think is better in terms of the longevity, because we know that the longevity of a hip replacement can be dictated by how you put those pieces of metal and plastic into the body. And on a separate note, as we get more and more into personalized hip and knee replacements, it allows us to make surgical decisions that are more personalized to the patient, not treating every patient the same way. Everyone has different shapes and sizes and bone types and anatomy types. So why not, treat every patient a bit differently and be able to make those decisions intraoperatively, or the pre-surgical planning is greatly facilitated with the use of robotics and navigation.
Excellent. On that last point there, you mentioned that this can be done either pre-surgically through your plan with this patient, or it can be done intraoperatively, or I assume both.
Yep.
How is this done pre-surgically compared to intraoperatively? What kind of differences in the robotics? How are you using them differently in these different stages?
So there's different types of robots that use different types of platforms. And some of them, most hip surgeons will have templated or taken an x-ray and got an idea of what the sizes are for surgery. And there's ways of templating or assessing sizes before surgery with just an x-ray and a calibration ball. As we move forward now with technologies, we're starting to use CT scans to give us a bit more detail to better template those implants that we're putting into the body. So that's the before surgery, where we're placing things on a plan or a sort of a direction for surgery. We do this with both hip and knee replacement surgery in terms of planning and understanding what we're going to do. Now, the execution of that plan has typically relied, up until recently, on just sort of human assessment and human measurements and sort of very crude technique. But now with robotics, we're able to really, as I mentioned, dial, that cup positioning or anteversion or inclination, or how far it is out of the acetabulum to the degree and to the millimeter. That can't be done without the use of robotics or navigation technologies, which allow us to make those decisions. Everyone's hips are a bit different. Some are wider, some are more narrow. So we have a plethora of different implants and sizes and combinations, but who we use and what often was very much a judgment call on a feel. But now we can actually take that feel and quantify it with numbers and get a really good answer to what that patient needs to make it feel their anatomy is better restored. Are they short by a centimeter? Did you lengthen them a centimeter? Do you not want to lengthen that hip? Did you restore offset? We're starting to talk about the spine and its relation to the hip and pelvis. And do we make accommodation on cup placement for that spine? And so all these things are only made better and understood better by surgeons with the use of these technologies.
Right, and with that, you're kind of going up the body there with the spine and how the hips interacting with the lower back and upper back. Are there distal effects that you're also considering in terms of how is this hip replacement and the angles that you're replacing this at, how it's affecting the lower limb as well? And are there
For
considerations
sure.
there?
It can affect your knee. The rotation of the femur is dictated by how you put that implant into the femur, how we're doing that, how we're measuring that, how we're assessing that. All these things are now getting looked at more closely now that we have the ability to look at these things more closely. Because without these technologies, these are all questions that we never even answered because we didn't even know they existed.
Right.
Right. And so now we are seeing how it does affect the spine, how it does affect the femur, how it can affect the knee, how leg length can change different things. So yeah, we're getting more and more information about these as we move forward.
Right. And where we are right now with modern technology, where would you say um, what delineates yourself as an orthopedic surgeon from what these robots are doing? How is it an adjunct to your care as opposed to taking over your care completely right now?
So I think all these technologies, at least in orthopedics right now, are all still assistive technologies. The surgeon is still making ultimately decisions and still making the actual surgical execution of that plan manually, him or herself, with the use of technologies. Now, whether that technology controls where he or she can make a cut or ream or place a cup, that's the additive part, but it's still the surgeon in control of that. They're not being left, alone with a robot and a patient to do these surgeries. Now, all that being said, on that spectrum, I think that's where a lot of us see this is going to, or eventually getting to, where these technologies become autonomous to the point where, they're able potentially to do the entire surgery all on their own. I think Elon Musk today said, that all surgeons are going to be, robots in 3 years. Now, I can agree with part of that statement. At some point, 3 years seems like a pretty tight timeline. I mean, especially here in Canada. But I think that we're going towards that because in any manufacturing or creative process, I think using technologies or robotics or precision always helps that process.
So pathway surgery patients, look forward in 3 years. Dr. Rodriguez will be placed by an AI robot and we'll have a new podcast
I'll
ready
just
to
be a
go.
chat bot. You know what I mean? Like it'll be just someone answering questions as they do your surgery.
Yeah. So we've previously discussed in some previous podcasts your preference in using the anterior approach with total hip replacements to improve patient outcomes. Can you briefly discuss on why the anterior approach is used, just to kind of
Yeah.
recontextualize what we're talking
So I
about
think
here?
the anterior approach, whenever you have a hip, first of all, any hip replacement done by most surgeons in most places is going to have a very fantastic outcome. It was called the operation of the century. That being said, I think that if we start to look at, different techniques to do it, if we're less invasive, and by invasive, it doesn't necessarily mean a keyhole incision. It means what you do to the soft tissues. So we've come to realize that anything you do in the body, it's not just how much skin you cut, but how much you dissect muscles and tendons and ligaments. And those are the painful bits. If you've ever sprained your knee, it can actually hurt more. If you sprained your ankle, that can even hurt more than breaking your ankle because bone isn't innervated the same way as a lot of the soft tissues. So, the way we treat soft tissues, and if we respect them more, you'll have less pain. Which is why with the anterior approach, whereby we're dissecting less soft tissue, not cutting any muscles or tendons, but going in between them, people seem to have remarkably much less pain to the point where they're surprised that they may not even need narcotics after surgery because really that incision pain and that burning pain is way less than their arthritic pain before. So personally, I'm a subscriber to anterior hip replacement. I've been doing it for over 10 years. We were one of the first sites to do it when we were practicing in Ontario, and I've extended that practice to here. And we've taught a number of surgeons of how to do anterior approach surgery, and I think the demand from younger surgeons to learn this technique, which is perceived as new, but is actually over 100 years old, originally described in France, is definitely catching on, and most surgeons are switching over. If we look to the U.S., well over 60% of the American Hip and Knee Society do anterior approach total hips. That number is significantly lower in Canada. It's about 15%, but we're slowly catching up as demand places pressure on surgeons to change their surgical practice.
Right. And how would you describe the timeline in terms of the development of robotic technology with the advancement of this anterior approach? What came first? Was it chicken or the egg? Like, was this technology able to meet the demands of this new procedure? I know you said it was
Yeah.
over 100 years old, but relatively newly introduced.
So originally, most robotics and navigational technologies were meant to address some of the issues or fault, problems that people had with lateral or posterior approach hips. Because dislocation was such a concern with the posterior approach of a hip, navigating and making sure leg lengths and cup positioning were okay were very crucial to the success of those surgeries. So the original navigational technologies and robotics were really developed for other surgical approaches. Now, fast forward to today, and especially in the US, where there's a huge push of anterior hip surgeons, we're looking for additive technologies to make that even better. And so everything at this point, you're taking a good operation, you're trying to incrementally make it better. And so I think by using robotics and using technologies to make the surgeon better, I think it makes the surgery a lot less stressful for me. I know I can reproducibly do it the same way every time. And I think that takes away a lot of the guesswork that I have. It makes me feel better during the surgery. Makes me knowing that the patient's going to have a guaranteed outcome of this is how it's going to look on x-ray. This is where everything I wanted to do on the plan was executed according to plan.
Right.
So I think all those things help. The more you can do and assure yourself that you're putting things where you want to put them in the body without dissecting. Because, if you want to open everything up to make sure everything is perfectly aligned, you can do that. But that involves a lot of surgical dissection. But if you can start to put things through smaller incisions and smaller dissection of the soft tissues, very accurately place them because you're using robotics or navigation, now you have the best of both worlds. You have a perfectly placed implant, but you didn't have to open up the whole body to get there.
Right.
So that means less pain, less swelling, less inflammation, less dissection, but a very highly accurately positioned component.
So even though surgical patients are under anesthetic during these procedures, I still think they want to know what's actually happening during the procedure. It's their body kind of. If you can go into what the specific plan and how you execute this plan for a total hip replacement, obviously robotically navigated as
Yeah.
well.
So let's say we've had our X-rays, we have had our blood work, we do our pre-op. We understand we're having a hip replacement today, and you come in, we're doing a hip replacement. You're gonna meet our anesthesiologist and our nurses, get IVs. You're gonna likely have a spinal anesthetic, maybe some blocks around the hip. Your anesthetist might augment that with some special pain blocks. You're going to be brought to the operating room and then placed in what we call the HANA table. The HANA table is a tool that we use to be able to do and facilitate anterior hip replacement surgery. It was developed by Dr. Joel Matta based on a prototype brought over from France, and it's allowed thousands of surgeons to learn this surgical technique very safely and reproducibly and make it easier. So we strap you into this table. We sedate you. We give you medications to make sure that you don't get infections and don't get excessive bleeding. We start the operation. So typically for these operations, it can involve either x-rays ahead of time or a CT scan or placement of pins into the actual bone to be able to allow for navigation. We get baseline information from the hip to be able to map it. So we register bony landmarks, we register x-rays, we make assessments of what the bone looks like before we operate on it. We compare that to our surgical plan, and then we do the operation. With anterior hip replacement surgery, we go through the front, in between muscle layers. We resect or cut off the head of the femur, which is that bone, on your hip side, the ball part of the ball and socket joint. We remove that, and then we begin work on the socket. The socket is your acetabulum. From there, we're going to ream or use a tool that takes out the cartilage and gives us good bleeding bone, which allows for the accommodation of a press fit or uncemented acetabular component. That's the cup. These cups are metal, and bone will grow into them and secure them to the body over time. Within that cup, we placed a plastic liner, and that's sort of the articular surface inside your hip. That's your new cartilage in your hip, if you will. We then go to the femur, and with the Hannah table, we're able to extend or hyperextend the leg, bringing the femur up. Once we have the femur delivered, we're able again to sort of broach or prepare the femur. What that involves is in placing different size sort of metal broaches to remove the cancellous or spongy bone within the hip. And once we have a good size, that's the component we're going to use. So any company that you use to do hip replacement surgery will have a plethora of sizes, not just small, medium, large. There's up to 24 different sizes of stems. So, and then different offsets, so different neck angles. So those are all things that we can customize for that patient based on the surgical plan and intraoperative assessment. We'll put that piece of metal into the body, and then again, trial with a bunch of different heads, because the heads come in different sizes and different lengths. And so that allows us to really tailor make your hip replacement. We then reduce your hip, take it, give it a feel, see what the assessment is of the soft tissues, see what the screens and robotic calibration and AI tells us about the numbers, and any final images we need. When we're happy, we put in the real pieces. So they take out the trial or practice pieces and put in the real ones. Then we stitch you up and bring you back to the recovery room and wake you up slowly.
Sounds very simple. Very simple.
Yeah, it's not as hard as people think it is. I mean, if you think about what it is, but yeah, it can be involved, but actually the surgery's come a long way. Originally it was like 3.5 hours, 4 hours for a surgery, and now it can be anywhere from 35 to 45 minutes.
And did that duration decrease by that much due to robotics, or is just other efficiencies that have taken place
It's
as
just
well?
everything. As people learn the surgery, we got better instruments, better tools, better understanding that doing an operation for 4 hours is not good for the patient,
Right.
by keeping the wound open, predisposing to infection, anesthetic times. So as people got faster, more efficient with better tools, they became better. And now we're at the point where even though we're using more technology and better tools, we're able to do a smaller, simpler operation with better results.
I wanted to touch on this idea of natural alignment because you previously mentioned our partial knee replacement podcast that people that present with either varus or valgus misalignments, you often or people think that you want to make it completely straight, but maybe that's not always the case in the knee because you want to retain some of that natural alignment for that
Yeah.
patient and how they're used to walking and their gait and so on. Is that the same consideration in the hip where you're still trying to maintain some natural alignment, or do you
No,
want something ideal?
I think that we've come a long way in our understanding of the hip in terms of like offset. So how much your hips stick out. So that's a big thing that and I try and teach the trainees or the learners at our institution that you can't affect that. So you can't make someone that doesn't have their hips stick out and then really increase it because that'll put undue pressure on their greater trochanteric bursa, on the muscles around the hip, cause soreness and pain. Conversely, you also don't want to lengthen someone's leg that's not used to being long. So if they're functionally short because of erosion of cartilage is one thing. You can restore that length of the leg, but you don't want to, lengthen them by 1.5 centimeters compared to the other side. They might need a shoe lift or feel off or cause back pain or knee
Right.
pain. So,
Right.
restoring that anatomy and that alignment to what they are 100% dictates a lot of the outcome and happiness that people have.
Amazing. What do you anticipate or hope for in future technology in robotics? Being practicing surgery, so you've been using this approach for 10 years and robotics for, I assume, also a similar amount of time. What are you hoping for the future?
I think there's two big things. So one is that the actual physical part of surgery, I think, is going to eventually be replaced, or more and more is going to be replaced by automation and robotics. So robots that can prepare the cartilage, ream, make cuts on their own more accurately. So I think there's that part of it where that manual part of me having to do something will slowly be replaced by additive technologies. But all that is sort of predicated on the fact that I think these technologies will allow for algorithms to make better surgical decisions. So it'll be able to take the information ahead of time, be it X-rays, CTs, MRIs, be able to determine, you're this old, I need this to last that long. I'm going to restore your anatomy to this position, which is optimal for survivorship and your satisfaction, and recreate that. So those are all things that, like, big data pools will be able to determine much better than me on any given day with the surgery. So I think that decision making and that algorithmic approach to personalization for you eventually will be, data AI driven. And then after that, I think that the mechanization of this whole procedure will be done Again, likely by robotics in the future, at least in my timeline.
Very interesting. So, do you think that's going to mainly play a role intraoperatively or in the pre-planning process of this as
I
well?
think both. So I think pre-planning will be done, and the execution of that plan will be done, really. But I think it'll also be faster, right? Like that pre-planning, instead of taking days going back and forth, I think about like it'll be instantaneous within seconds. It'll be able to make a plan based on a pool of data that you or I wouldn't be able to comprehend, and then surgically be able to make those decisions much faster.
Right. And you've alluded a few times that total hip replacements is a very successful procedure overall, even relative to other surgical procedures that are
Yes.
out there. Maybe I think the top one or the second.
It's the second after after cataract. So
Yeah.
yeah, yeah. The eye dentists still have us, but after that, it's hip and then knee actually.
So do you think the advancements of robotics pushes it even further than that? Or are we still in the same similar patient outcomes, but maybe more efficiently getting there?
That's a good point. I think one, in terms of efficiencies and planning and stuff like that, for sure to add something. In terms of confidence to the surgeon and stress levels, I think it helps the surgeon. I think you're taking a surgery that has like, 95+% good to excellent results and like trying to really get that, a little bit higher. That being said, I think like, a lot of these scores and when we look at, what's a good outcome for hip or knee, like classically the patients we were operating on, you know, they were older, they're just happy to walk around without a cane or play with their grandkids. Like now I got patients ask me, when can I go heli skiing? When can I do, my Pilates class or jujitsu? Like these are questions that like 5, 10, 15 years ago, like no one got, right? Or people are like coming back and saying, well, my hip replacement's a bit sore. And I'm like, well, it's only 4 weeks out. What have you been doing? And these are people that are like, cycling 100 kilometers on the weekend or trying to really push the boundaries of what we can do. So, I think the expectations of patients have really come up. And so I think every little thing that we can do to make that surgery better for that patient will give them that quality of life that people are really starting to look for now in terms of good answers.
And expanding on that, what would you say a great outcome for a patient looks like for you, both clinically and personally?
I think the biggest compliment you can get from a patient is, if they come back at 6 weeks or 12 weeks or whatever and be like, they they don't feel any pain. And often they will have said they have to think about which side they had to operate on. They can't even remember. And once you know that, that's what they're thinking, then I think that patient has a good outcome. They're able to go back to their activities, their loved ones, their sports, their travel, be pain free, be able to get a restful sleep. And often we see that even with partners of these patients, the partners come in and they're like, thank you, because those people are less affected by the stress and pain that the patient had. And I think that to me is really a happy time when you're able to do something that you get to do every day and really affect change at a medical level that many other different aspects of medicine, unfortunately don't have those life changing sort of treatments that we can do.
And at extremely high volume as well, and just making sure the whole process is efficient so you can take care of as high of a volume of patients as possible.
Absolutely. I think efficiencies, surgically, and clinically are important, especially in the Canadian healthcare system. Like the more we can do, the better. And in terms of servicing our public.
Right. I think popular segment of this podcast is myth busting here. So I went to
Myth-busting.
Google,
Yeah. Oh,
got some fun total hip myths, and I need you to confirm whether they're true or not. Starting with number one, arthritis is a part of aging. You got to live with it.
so I think it is. So in degenerative changes, like we said, like your whole body, regardless of who you are, will break down over time and over years. And as I said, the cartilage is no different than the rest of your body. Now, that being said, arthritis is part of natural aging, but that doesn't mean we can't do things to help treat the subjective sequelae of that. So, if you're having problems moving around, if you're having pain, if you have to take painkillers or you can't do the things you want to do, know that there are good options for you, non-surgically and surgically. So, arthritis can be a part of natural aging, but there's good answers for that if it's affecting your life.
Right. Two, a hip replacement won't feel natural.
Oh, I would disagree with that. I think a lot of patients, say even more than like a lot of them come in, they can't even tell which side they had done or have to remember. So I think it'll 100% feel natural, and if it's done well, and in most cases.
Lastly, those with severe hip arthritis, because it's a graded process, cannot get a hip replacement.
Now, again, I disagree with that. I think like age and medical comorbidities aside. So I think if you're fit enough to undergo the rigors of surgery, the strain on your heart and lungs and everything else, and willing to put in the time. Because often those patients that are really severe are pretty deconditioned. Their muscles and tendons are pretty weak. So they do take a little longer to recover because they haven't been able to walk properly for years or, months or whatever it is. And so if you haven't put much weight on that leg and the body hasn't seen that stress, It can take longer to recover. But absolutely, are you not a candidate for surgery? No, I would say that, it would take a lot to turn down someone from surgery. And usually those decisions aren't based on the x-ray, but really dependent on the rest of their physiological health.
So you're saying arthritis is an inevitable part of aging, but what can people be doing to stay out of your clinic and prevent that process or maybe attenuate the increase in arthritis as we age?
So I think to stay out of the clinic, I mean, that's a tough one, right? Because even I mentioned sometimes genetically there's a component. Like, if all your siblings had hip or knee replacements, you might likely be on the same train regardless of what you do. I mean, I think anything that keeps your general health healthy is good to do. Keeping your weight down, exercising regularly, mobility exercises, not extremes in terms of, physicality. I think those are all things that you can definitely do to help, protect yourself to a degree or stay fit. More importantly, you're staying fit in case you need to have surgery done. You're going to recover from it much faster, much better. Um, there's no magic pill or glucosamine sulfate or, something that you can take that'll prevent you from getting osteoarthritis. If you look on the internet, a lot of people will sell you a lot of different pills or injections that can help prevent or reverse osteoarthritic or arthritic changes, which I don't think there's any scientific evidence anywhere that shows that yet. Maybe one of the strongest things that we can look forward to in the future is something like peptides. There's a lot of talk about peptides, especially if
Yeah.
you go on social media,
Yep.
age reversal and stuff like that. And I think maybe that holds a part of the key in the future, and maybe you can unlock that and help mitigate some symptoms earlier on. But as of now, I don't think there's anything you can do other than, it's hard to tell you like, well, avoid getting in a car crash or avoid, having traumatic incidents. You still have to live your life. So I think you have to live your life within, the limits that you can do, but try and really push those limits to be as active as you can while you can.
Active as you can, but also making sure you get the recovery as well
Yeah.
to
I think recovery is important. I think, understanding exercise and understanding your body. I mean, some people can run 10 miles 5 times a week and some people just can't. That's too much for the body. So you have to understand what the limits of your body are. And you can certainly push those limits and change them. But some people are just built to do different things.
right. Dr. Rodriguez, do you have any take-home messages for us today regarding robotically assisted total hip replacements? How can we summarize this the
I think
best?
a lot of people will say you don't, hip replacement's a great operation and you don't need robotics or navigation or technologies. And I think they're coming from a place where, they feel that they do a good enough operation. And I think for decades we've shown that it's a very successful operation. But anything that makes the surgeon better or more confident or more accurate, I think shouldn't be dismissed and should be embraced and sort of used. And I think really that's what it's about. It's like, does it make me better? Yes. And does that affect change for the patients? Maybe not every patient can now, dunk a basketball, but what it means is that like more accurately, most of the time, most people are getting a better operation. So I think it's something we should start to do more and more of. And you're going to see more and more surgeons are going to be offering those technologies. And so I think that is really the way of the future. And take home replacement is if you need a hip replacement, you shouldn't be scared of it. A lot of people are scared of surgery. This is not a long surgery. It's not a surgery where you lose a lot of blood. It's not a surgery with theoretically a lot of complications compared to other surgeries. So, if you're a candidate and if you're worried about surgery itself, you should definitely get cleared by a doctor. And if you're cleared, you should definitely have that surgery.
I think that's a fantastic message to leave on. Dr. Rodriguez, it's always a pleasure having you in the studio.
Oh, my pleasure.
It's been another episode of the Pathway Podcast. Thanks, Dr.
Thanks,
Rodriguez.